Good morning. This one is for teaching purposes, differential diagnosis, not morning coffee talk. So I want to share a case that I've been working with, and it really has been diving into symptoms. And yes, we talk often, we don't chase symptoms because that's where we end up in rabbit holes, and pain is elusive, it can move around, and our work really is focused on efficient mechanics. And as we know from our work in efficient mechanics, when mechanics are not efficient, either in that area or because of compensations, that's where we get into degeneration and pain. So, however, I have a patient who had been treated by all of the body workers, and I'll say body workers because most of them are in the massage therapy world, and not that we aren't body workers. We are, at the same time that we are medical professionals, as we go into more of the diagnostic work. And as this gentleman came in, I was very clear. I said, hey, I'm not just going to work on your tissues. We are going to dive into your mechanics, dive into your history, really understand what are some of these pieces that contribute to the struggles that you have in your body. So where I go with this, as a lot of my work goes with the listening. So again, as I see him, I watch him walk. Yep, we need posterior depression, abdomen extension. This pelvis does not move at all. So I see him with mechanical eyes, absolutely. But I also, and probably even more so, I see him from two more sets of eyes, and those are my trauma compensation theory eyes, as far as what's happened throughout his lifetime that has got him to this point. And then the other one is the visceral, vascular, neural set of eyes that I use. So as I worked with him, starting with the listening, again, I have really, really embraced the listening, and I trust the listening, and I trust the innate wisdom of somebody's body, and especially when someone has been through so many practitioners, and they've been through so many therapists and doctors, and they still have some struggles. So that's where I absolutely dive into, hey body, hey tissues, hey innate wisdom of the cells. Again, take it back to embryology, and even through IPA, take it back to the developmental sequence, right? Nobody told the baby to work his or her core, right? Nobody told the baby how to crawl. Nobody taught the baby how to crawl or how to walk, right? So back to these innate developmental sequences that just happen. That's that wisdom in the brilliant body. So we know that it's there. Again, we can't really taste it, touch it, or feel it, but we know it's there. So tapping into that as we go into the visceral world, again, back to embryology, same concept. These cells migrated and did everything they need to do in the womb to become a human, and no one told them what to do. So that's the work that we do, is we tap into that innate wisdom. And even I'll take it one step further, right? All the things that happen in your body every day, right? The gallbladder is making bile and squirting it out at the right time. Who's telling it to do it? Nobody, right? Actually, not nobody, but the innate wisdom of the body and the interconnectedness of all these systems to keep your body running. So, backstory on why I love the listening. So back to the listening. As I work with him, I believe that very first visit, he took me into the cranium, and I'm finding so much in my patients with back pain, and especially back pain that has had surgery and lots of treatment. Significant dural neural tension still. I'm just using plain old slump test. I'm not even putting arms behind the back. But again, we can feel that first catch, if you will. And somebody who doesn't have that subtle feel, will take them past it. And that's where we've blown past that first barrier, that first catch. But there's an easiness, there's a give to that initial clean where there's no dural neural tension. It's easy. And then you start to get some drag. I'll call it drag, where it's a little heavier. We can work through it, but there's some drag. So that's that first catch, and that's where I believe that first neural tension is. So that's where I document when I document my neural tension. So for him, absolutely some significant neural tension, right greater than left. I think maybe I gave him a 35. Again, full 90, and if you go past, right, 95, 100. But starting from foot down, sitting on the edge of the table, 0 to 90, probably 35. So, but the listening took me to his cranium. So thinking about the relationship of the entire dural system, and as we look at the body as an entirety, tension on the dura, tension on the falx, tension on the tentorium from old head trauma, which we sniffed out. He had some. So that's where we started to work. And then I continued to take the listening further. I'm trying to remember where else we went viscerally. And I retested neural tension. Pretty clear, looked pretty good. And then I took him back into gait. And what was interesting is actually the gait, while it was better, there was still this it was a hard, so first off, the man could not move, period, in gait. And I will ask permission to use his videos because it's going to be really exciting to watch his gait change over, gosh, I've seen him, I think, 4 sessions now. So, but to watch his gait change. So, however, what happened as I took him back into gait, I just treated him by the listening. I just treated him visceral, vascular, neurally at the time. So, I got him up off the table. Neural tension was much, much, much better, much cleaner, much lighter. But as he went to walk, so his gait was better. It was more free, but there was this, but again, it changed. So before he didn't have really any options for movement at the pelvis. And again, I will show you these videos as we go. But I didn't like, there was a harder landing that was different, which he didn't have before because he couldn't access it. So I didn't want to send him out the door like that. So I brought him back on the table, and I did jump into some mechanical pelvis. I believe I went into a little bit of a nominate extension. I have to look back. I'm not sure if I went AP, but just a little bit of mechanical pelvis because I just wanted to soften that gait as he walked out the door. So I retested neural tension. Maybe I lost a tiny bit, but not much. And we'll talk about how I use neural tension, like when I get it, and sometimes I lose it, and I don't ever want to lose any neural tension. I gain because the neural flare. So we'll talk about the neural flare in depth, but again, we learned the hard way. Again, I flared somebody up because I treated mechanical. I didn't reassess their neural tension. I don't even think I tested their neural tension. And 6 hours later, oh my gosh, Jen, I am in so much pain. So I had improved the mechanics and improved the mobility, which is what they needed for gait. However, the underlying dural system, neural tension, it could not handle that increase in demand that we gained by improving their mechanics mobility. And like I said, I'll dive into that, and we'll break that down. But, so I sent him out the door, like neural tension is still pretty good. Okay, I feel good about bringing those mechanics on. And I don't think I'm going to tip him over the edge of neural tension. It was just our first visit. So he came back, he's like, oh, I was, a couple days later, I had a little increased pain, but it wasn't terrible. So second session, I did do some listening, but I spent more of mechanics because the changes we made in his gait, wow, they were phenomenal. That gait was good. It was smooth. So it was much more functional mobilization, much more anominate anterior elevation, posterior depression, just treat, trace, and isolate, just improving those mechanics of the pelvis, sacrum. I did start to go AP because, again, as I looked at leg swing, significant shear forces on that 4-5 segment. It just continued forces, just 5 and above again because the anominate did not clear well. Anominate hip, coccyx, sacrum could not clear well. So as he goes to walk, every step he takes, shear forces into L4-5. So he comes back a week later. 2 days later was really, really, really bad. And again, thinking about neural flare, he didn't flare up that night, so I really wasn't sniffing out a neural dural flare. Just, okay, how is his body changing? Because we're changing his body, we're changing his mechanics, improving his efficiency on his gait. And so as we think about, he comes back with his symptoms, or he's like, both my legs were really, really sore and achy, into the, especially the left side. And then, so again, I'm thinking L4 as we go into the quad. He's like, left side calf, wow, right? You really irritated that L5 nerve root. But still not thinking it was a neural flare. So, and to the point, he's like, I can't sleep. I have so much pain. So this is where we're diving into, so important to really understand the nature of the pain we're dealing with. Again, this is where we're going to go micro. So we're always looking big picture, but we still need to dance in and out, in and out, in and out. So as we're dealing with his pain and his symptoms, all right, what is it? Okay, I know that nerve root is getting irritated because of where he told me his symptoms were. It was interesting that it was 2 days later, so that one kind of threw me off the trail a little bit. And it didn't sound disky because it wasn't first. So yes, nighttime. So maybe there was a slow disc swell, which I'm still working on my hypotheses for him. But it wasn't so much stiffness in the morning. So I wasn't sniffing out the disc so much. I still haven't discerned it all the way. Anyway, all right, 2 days later, really, really bad pain. So get back to like, what changed? You know, what did I change in his system? And then how did his system adapt to it? And as he came back in, neural tension was okay. I didn't lose too much. And I treated, and again, your story, I haven't done your story. But it happened again. So this time I really broke it down. Here's where I'm going with. So here's where I really broke it down into, all right, what's going on mechanically. So we went right into gait, right? That's something he does every day. He's going to walk. So I watched him walk, and the more he walked, he's like, it is talking more in my left calf. So I'm like, all right, as he walks, right, thinking about innominate extension, hip extension again, that what is needed, what's your question, what is needed for him to walk somewhat efficiently, and then how that lack of, like, whatever's happening through that left side, creating this little force with each step he takes, irritating that L5 nerve root, and probably above the whole system, right? So we broke it down. So I knew that, all right, when he walks, that's irritable to him on that left side, and the more he walks, the more it is biting him. So we did improve that innominate extension. So now that we gave him some more mobility, it's created kind of this, all right, here's this next strain, or here's more mobility, which is wonderful. We've increased the strain on the nerve root. How? So that's what we're going to start to tease out. So I went into the listening a little bit, but I really broke down. We even went into, I call it the cha-cha, with left leg back, right leg forward, and yep. And we could see how, as that innominate, as he tried to get into posterior pressure, innominate extension, hip extension, again, just still there was this force, this shear force up above L4, L5. So thinking about tug of war and looking at him from the front of the pelvis and the spine, okay, something is not lengthening. Is it shear force that's banging on that nerve, or is it something that is tugging on the nerve from the front every time he lengthens his leg? And I'm sorry I cannot show you visually as we look at leg swing. There's a couple of videos where I break that down and looking at it as the leg swing. How well do the mechanics go through? And Greg in our FM classes, we break it down into hip, sacrum, and pelvis, and the extension. So again, looking how movement flows through the system, but again, in this case, and in my case, we're taking into standing in a leg swing, watching the movement. How well does it go through? Where does it stop? Where is there too much movement? So, but then we look at it from the front. So leg swing from the front. So how well do the tissues lengthen? Because if they don't, that leg is not going to be able to come back into efficient movement or mechanics that is needed for you. So we dove AP, and I'm going to have to come back to this video to go into the detail of what I did. But again, diving AP. So what's happening? So we brought the right leg up into flexion because we're not too concerned about right leg right now. But when that leg goes into extension, what happens? So both legs up, he held his right leg kind of like a Thomas test, if you will. Actually, I just had it in bed. And then as he slowly slid that left leg, I made sure I'm down on that L5, L4 anteriorly. So what's happening to the tissues, the fascias, the flavum, the multifidus attachments, the nerve roots, the plexus, the organs, peritoneum. So what's happening with all those tissues as he slowly slides his leg? So instantly, he didn't get very far at all, and pull. There was that pull under my fingers. So we very lightly teased out those tissues to encourage and allow for sacrum, coccyx, hip, lengthening, extension in gait. So with slight flexion, the opposite pelvis working on extension, because again, reciprocation is what we have at the pelvis in gait. So trace and isolate is what I did with that, and very gently knowing, okay, we've got there's a vulnerability that is easily provoked. So we work pressure on, pressure off, and again to get those tissues freed up. So we did actually a great job of working that, get the tissues off, and then working the vertebrae AP, which again is such brilliant, brilliant work. Please, if you haven't, dive into that work. We learn it, I believe, in FM, upper or lower. And the courses have changed over time, but again, that really is brilliant. So Greg Johnson is the anterior posterior approach to lumbar spine. It's brilliant and so critically needed in our world. So again, cautiously, right, as he walked, we took him back up to walking. He's like, wow, that's better, right? So as he walked, like, there's not as much, he wasn't getting that instant pain and pull into the calf. And the cha-cha was better, the mechanics were better. And then I took him into some NMR, again, just resisted. I used the upper. It was hard for him to fire through the femurs as I'm working on the magnetic flick, Johnson's work. And so actually I ended up using bilateral upper extremity down low with a lot of traction to facilitate core from top down. And he did really, really well with that work. So he got off the table, felt great, moved well. Neural tension was pretty good. So I felt pretty confident. All right, I think we're getting this off the system. So again, 2 days later, actually, I chatted with his wife. So 2 days later, here comes increased pain. Though it was not as bad as it was the first time. So again, he did. It's like I had to take a lot of pain medication that first time, which again, when we do our work, sometimes we open up a little hornet's nest. And one of my favorite old patients, you can break me as long as you can fix me. So sometimes that does happen. We kind of sometimes blow things up a little bit before we figure out all these pieces. I don't like it to happen that way, but sometimes that's just the nature of the beast. However, a rule of mine as I treat my patients is I don't ever want you to not be able to sleep. So if you are not able to sleep because of how your body responded to the work, like that's a deal breaker for me. We need to figure out, all right, what is it that changed in the system? What is it that your system did not like? And this is where, if you'll see, I gravitated away from the listening. And I went more into looking at his mechanics because we made such great changes. The gait was great. He loved it. It felt wonderful. He left, right? My last table, we really got some tension off that. The mechanics, the gait, awesome. But then 2 days later, there's the neural flare. So then I realized, oh my gosh, you are a subtle dural neural flare. Like usually it's that 6 hours of whoosh. But for him, delayed dural flare. So as we problem solve and piece that out, so a couple things I said, hey, I want to feel your system. What happens 2 days later? Like you felt great for a good day and a half and then things got a little worse. So again, thinking about mechanics, who's getting irritated as we improve the mechanics of his pelvis? Something is squawking and talking. And again, the pain is different. I mean, he's had this pain on and off, but again, kind of different from what he presented with. And again, a pain he probably hasn't accessed in a long time because he couldn't. So as he came to me, he really didn't have much movement, period. So if he didn't have any movement, he never got to that mechanical point where he provoked that nerve root, right? So then as we start to improve mechanics, which we need, it took us to, it kind of uncovered this deeper vulnerability and kind of structural functional tissue issue. So as he came back in, again, a great sport, and I'm talking him through the whole thing the whole time, like, all right, we're starting to uncover some things. Let's see what we need to support that as, do we go further with this work? Because he needs it, but we don't want to uncover a vulnerability that creates more pain for him. Or if we do, we've uncovered something, how do we support that? Whether are we going, we're going to plug regenerative medicine, what do we need to do, again, as we look at the big picture to improve his quality of life? Because as he came to me, quality of life was not phenomenal. He could not walk very far without pain. Kind of just general pain, like a lot of pain through his legs. And again, because he's fighting his mechanics. So he wasn't in a great place to start with. We're changing things. Things are revving up a little bit. All right, so anyway, where he came in this time is I said, hey, I'm really going to first time, second time, third time. First time was maybe 75% listening, 25% mechanics, and it increased the pain, but not nearly to the effect of when I went full on mechanics and didn't go with listening so much. So this time I said, hey, we are just going to listen to what your body needs. And sure enough, his body took me to the cranium. So we went into the cranium, into the dural mechanics, and I believe he took me viscerally. So I stayed viscerally. We got into the stomach. We got into the diaphragm, esophagus, into stomach, and started working our way, visceral, fascially. I don't think vascular picked up. I have to go back and look and see. And as he came off the table, neural tension was beautiful, so light, so clean. And gait was okay. Again, not as beautiful as when we treat the mechanics, but it was okay. And given the nature of how he's responded when I treated him more mechanically, we're okay with that. I was okay with that. Again, that's kind of where how can we improve things? Sometimes that's good enough for now. So I put him back on the table, and I think I still stayed with the listening, and then he came back off the table, and then I lost a tiny bit of neural tension, but not much. So I, again, felt pretty confident. I do have an SI belt, which helps him tremendously as well, because we just need support through that lumbar pelvis region. And so we will see. But I do have him scheduled for 2 days from yesterday, because I want to feel. So kind of where we left things is, if things flare up, I want to feel in your system. I want to go into the listening and see what that system is squawking back at us, what it's asking for. But I have a hunch I don't think it's going to be as bad, because I did not push the mechanics. So it really becomes a dance. It's a balance, especially in our patients who, yes, there is mechanical trauma. We've got to look inside the container as well. And it's a balance, right? What tissues are protecting themselves? In the tenets of osteopathy, right? Artery reigns supreme. Dural system will protect itself. Again, vital organs will protect themselves at the expense of. So here we come in, super excited, right? Let's work our mechanics. Let's improve gait. Beautiful. But as we did that, how do those changes in mobility affect these deeper underlying structures? And did we, as we improve the outer mechanics, did we increase vulnerability or increase a strain on deeper, more vulnerable tissues? And that's what I believe is happening in this case with my patient. So we proceed super with caution, and we don't muddy the water too much. I'm going to be using more listening, knowing that we do need to get into the mechanics, but his body isn't quite ready. We have more container work, contents work, before we can get to some of his container work. And often when we work the contents, the container frees up pretty good. In this fella's case, as I saw in Gait, right? I freed up, we worked on the contents, but the container didn't respond as I had hoped it was. So yes, we need to do some container work, but his body's not ready for it. So such a dance, the art of our work, the art of our hands, our problem solving, our diagnostics. And this is where, yes, we do body work, but we are, we work in the diagnostics, and we work in the problem solving, and we work in the medical aspects of things. And again, that really is the beauty and the gift of our work as integrative manual physical therapists, as we incorporate all of these components to our patients. But when you gotta know when to hold them, know when to fold them, and that comes with experience, that comes with mentoring, that comes with learning the hard way as well. We learn the hard way from our patients, and hopefully they don't get too upset with us. Some do, but again, that's how we learn, and then we know going forward what we can do to help that next patient. Thanks for joining. Holler with questions. Can't wait to mentor you.